Welcome, everyone. I'm Rita Goldberg of the Cary Lecture Committee in Lexington, Massachusetts, and I'll have the honor of introducing our speaker, Dr. Paul Farmer, shortly. But first, 2021 is also the 100th anniversary of the Cary Lecture series, which was endowed in their wills by two remarkable sisters whom you're going to see on the screen, Susanna E. Cary, labeled, and Eliza Cary Farnham, also labeled in memory of their father, Isaac Harris Cary. Their pictures, as you see, are there. And they did this to remember their father and to benefit Lexington, where they had enjoyed joyful vacations. This is an important thing. These sisters were full of joy in life and also very liberal in their ideas. They created these free public lectures to, and I quote, on such educational or useful subjects of a non-sectarian or non-political character as may promise benefit to the community, unquote. We stretch those terms a little bit at times, I must admit. At the time, Lexington was largely a farming community, not as it now is, an extension of Cambridge. Over the years, we've had many wonderful speakers, including Margaret Marshall, then Chief Justice of the Massachusetts Supreme Judicial Court, Gwen Ifill from NPR, historians Doris Kearns Goodwin and Jill Lepore, and now Paul Farmer, among many other distinguished guests. The series was one part of the Isaac Cary Charitable Trust. The estates of the sisters also funded the construction of our beautiful Cary Hall, the Cary Memorial Building, where the lectures are held in non-pandemic times. It's also the venue for voting, town meeting, the Lexington Symphony, and other performing and community groups. The rest of the money from the sisters' estates was used to fund the Isaac Harris Cary Educational Fund, our umbrella organization, which has provided valuable information for these remarks. In this centennial year, the Cary Fund would like to recognize and express appreciation for the generosity of the two sisters and of the Cary family in general. Since its founding, the Cary Fund has provided hundreds of college scholarships to Lexington students, with most students receiving funding for all 4 years of study. It's historically been one of the most generous scholarship programs available to Lexington High School graduates. We all think the Cary sisters would be proud of what they've achieved, and we all thank them. And for more details about the local history of the family, there's a lot more, and we will post it. Please see carylectureseries.org, which is our website. So that's part one, our 100th anniversary acknowledgement. And now I will introduce Paul Farmer immediately. But first, I have a couple of important announcements. Nothing ever happens fast enough, does it? First, this session is being recorded by LexMedia. Thank you very much, LexMedia, and will also be available on the Cary Memorial Library YouTube site. Thank you, Mina Jane and the fantastic library staff. Thanks also to Jane Whitehead of the Colonial Times and Ross Christian Tello of the Lexington Minuteman for their excellent interviews with Dr. Farmer. Second, and this is important, please put your questions in the Q&A and comments in the chat, both in Zoom at the bottom of your screen. At some point, my colleague Maggie Pax will join us to offer audience questions. And now, finally, I'm happy to introduce our distinguished guest, Paul Farmer, who has been waiting patiently in Freetown, Sierra Leone, where it's past midnight, while we celebrate the generosity of the sisters who gave us so much 100 years ago. Perhaps this generosity is very much, I see Paul there laughing already, perhaps this generosity is very much in the spirit of Dr. Farmer and the organization, Partners in Health, that he and his colleagues founded in 1987. Please correct me if I make any mistakes.
Right.
To bring excellent medical care to the neglected populations of the world. Dr. Farmer began in Haiti the year before he even entered Harvard Medical School. He had a degree in anthropology and endless energy and compassion, and eventually, with the other co-founders of Partners in Health, did astonishing work in many other countries, always including Haiti, some of which are Peru, Rwanda, Russia, and now Kazakhstan, Sierra Leone, and Liberia. Wrong?
That's right.
In our own country, there are PIH workers in our own Roxbury and in the Navajo Nation. As the subtitle of Dr. Farmer's talk suggests, the staff of Partners in Health have experienced many plagues and epidemics before COVID-19, TB and drug-resistant TB, AIDS and Ebola, and have had astonishing results, often in the face of the conventional wisdom of national and international organizations. Dr. Farmer, as you've seen on our website doubtless, is a university professor at Harvard, chair of the Department of Global Health and Social Medicine at the Harvard Medical School. I have to read all this because the titles are so impressive, and chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. Despite all his titles and his work as chief strategist at Partners in Health, Dr. Farmer, whom I'm going to call Paul from now on, has never neglected hands-on clinical work. That's true too, isn't it?
Yeah, I was busy today seeing patients.
Oh, great. So that's good. And he has written many academic papers and a lot of books, which I can't quite count. I think it must be 14 or 15, something like that.
I'm loving this introduction, Rita. I could stay up forever.
All right, I'm hurrying.
No, I'm saying I really am. I'm so grateful.
Oh, well, don't be.
I'm the cockles of my heart are warm already. I mean it. I mean,
we'll just get going.
Thank you. Don't stop. My mother may listen to this.
Anyway, I'm now completely disconcerted, but the most recent of these books is Fevers, Feuds, and Diamonds. It is my great pleasure to introduce Dr. Paul Farmer, whose topic tonight is The Color of COVID, Reflections on Pandemics Past and Present, but I know what he really wants to tell us, first of all, is what brings him to Sierra Leone. Paul.
Thank you, Rita. And let me just tell you why I'm chuckling. First of all, because I'm so moved by the generosity of the invitation. I know you know, because when we met by chance at Harvard in some stuffy little event, the reason we were cloistered in a corner and talking was I found out that you're a supporter of Partners in Health. And so are an awful lot of people in Lexington. I mean, we've gotten through a number of difficult times in the history of this organization, or set of them, thanks to folks in the Boston metro area. But a second, when I was thinking, when you were introducing me and talking about the book titles, I was thinking of this experience I had years ago. There was a girl with a cancer from Haiti, and she was 5, and which happened to be the age of my older daughter. This is some years ago, a long time ago. And her parents came up. She got care at the Mass General, in fact. I'm a Brigham guy in all matters, but they have pediatrics. So, and there was a Harvard student who now is a Jesuit priest, by the way, and working in Haiti. And he was enchanted, even as a freshman, with Haiti and Haitians. And he was friends with a lot of Haitians. And he came over to the apartment where we were staying. We're staying in a faculty apartment, and this young girl was there and her mom. And the Haitian kid came in and said, "You're Paul Farmer?" And I wanted to say, no, I took a knife to him and then usurped his apartment. But I didn't say that. I said, "Yes, I am." And he said, "Did you write The Uses of Haiti?" Naming a rather obscure book. And I said, "I did." And then the mom of the patient said, "Dr. Paul, you never told us you knew how to read and write." So that's what I thought of when you said 14 titles. And what I'm doing here is, still working with Partners in Health. And Partners in Health, as you know, and said in your introduction, works with local authorities to build up local capacity. Yes, we deliver clinical care, but very rapidly, that takes the form of doing 3 things. One, taking care of the critically ill or injured, which is, after all, why we're invited into a clinical desert in the first place. 2 is to learn while doing it, which you'd want, any kind of university-affiliated NGO to do. And then 3rd is to really train people to do that. So My experience today in the hospital in Eastern Sierra Leone is nothing like my experience in our first years in Sierra Leone, which were at the beginning of the Ebola epidemic, or not even at the beginning, I wish, but several months into the Ebola epidemic. And the difference is when you have the staff, these, and again, now they all seem so young, the nurses and doctors. You have the stuff, the supplies, you have the space. We reopened a hospital and the systems, and can give patients support. People get better. So what we did today or yesterday was pretty epic. The Minister of Health came all the way out to the hospital, and a whole bunch of other officials, and of course patients and staff, and we broke ground on a new Center of Excellence for Women's Health. So all of the listeners who support Partners in Health, this is what we can do with that kind of support. Now that's probably longer than you wanted, Rita, but you know, it was a very exciting day.
It sounds very exciting. And one of the things that I learned from the little video that I got in the mail was how high the maternal death rate is in Sierra Leone. Could you talk about that before we?
I can. You know, I didn't see the video, but I would imagine it may have quoted the Minister of Health or some other, the Minister of Health or some other dignitary. But you know, if you look at a maternal mortality, that means the number of women who die during or as a consequence of childbirth. And you know, in Finland, that number is routinely close to zero. I think Iceland, it's zero. A lot of countries in Europe are close to zero. The United States does very poorly. And again, this is a reflection of our I mentioned the color of COVID in the title of my talk, but the color of racism and how it works its way into women's bodies. I mean, they're really, this is the area where we're left after serious study of why so many American women die in childbirth. But that number is nothing close to anything on this continent. Rwanda was very troubled after the genocide against the Tutsi with a maternal mortality that probably exceeded 1,000 per 100,000 live births. And in Sierra Leone, even before Ebola came to sully the place, or before we knew about it, the number here was 1,300 per 100,000 live births, which made Sierra Leone #1 in the world in maternal mortality. And Sierra Leone, since the war, a civil war ended in 2002, has routinely posted very dismal figures, but they're all improving. Because if you have, you know, if there's no more conflict, no more war, then you can pay attention to that task of getting together the staff, stuff, space systems, and support you need to make childbirth a safe process. But right now, they're struggling because that requires things. It's not something you do with family planning alone, right? We're talking about, you know, women delivering babies and the complications, as we know, of obstructed labor. Many of them are surgical complications. So without a blood banking system or a hospital worth the name, it's a very, very serious risk to have a baby here. Now we're hoping to change all that, and we're seeing it change, as the Minister of Health pointed out. And they're not happy with where they are right now. They may have maternal mortality just with a couple of years of concerted effort, but it's a long, long way before we're going to be at Iceland levels. But one day, and one day soon, I hope.
Well, in this case, you also have the support of the government, which must be tremendous help. But I was wondering whether you might want to amplify the title of your talk, as you began to do just now, The Color of COVID, and then the reflections on pandemics past and present, because I found myself thinking about the success story of Rwanda, which is was a similarly ravaged country by war and disease, and how that was all reversed by that extraordinary woman and you.
Well, no, she is awesome. And you're referring to Dr. Agnes Binagwaho, who's a pediatrician and was for 5 years, which is a pretty admirable run, was Minister of Health of Rwanda. Before that, she was in the lead technical position, which in that country is called the permanent secretary. And before that, she was director of the National AIDS Program, which is how I met her. But she is a titan of global health, not just in Rwanda, but you know, she would be well known, certainly in the United States as well. But the thing about Rwanda, before I go back to the color of COVID, is, the reason we keep going on about Rwanda, and I noticed yesterday with a lot of the officials from the central government, obviously there's local government as well, and the parliamentarians showed up and the mayor. It was, given that we're usually around staff and patients and trainees, it was quite something. But they all talk about Rwanda too, and I think the reason is, what happened in 1994, the genocide against the Tutsi. What a rebuke to not just humanity but hope. And I remember, although it took me many, many years to confess this, certainly in Rwanda, I remember thinking, how do you ever come back from that, right? Where you have genocide at close quarters. How do you ever come back from that? And I know you've written about this topic on an intimate level from inside your family. But that's why it is such a tonic, I think, elsewhere on the continent, and it should be a tonic in the United States and anywhere else. What they have done is the most massive reversal. In fact, I can say, as I have with a number of my colleagues, we put this in print, the declines in mortality registered in Rwanda over the last 15 or so years are the steepest declines of mortality ever documented at any time in any place in human history. And if Rwanda can do that, well, so can Sierra Leone, and so can Liberia, and so can Chad, and go right through the list of troubled spots. It gives us a great deal of hope. The color of COVID, I'll just say, at the time that I chose the title for the Cary Lecture, I was feeling, like a lot of Americans, a great deal of pain about the uniquely poor performance of the United States. And don't forget, I'm a big cheerleader. No other country would have had a Tony Fauci who could say, hey, for a decade, we've been investing in a platform that would enable us to have effective vaccines, even if they're an entirely new class of vaccines. So we pulled that off. I say we as if I were involved in the vaccine research. But it's a very painful thing. It still is, to look around and say, why have we had so many cases and why have we had so many deaths? After all, we do have staff, we have stuff galore, we have plenty of space, meaning clinical space. Even when we had to repurpose it, we know how to repurpose space so that it's safe, right? What we really lacked was systems, right? And adequate support. So, who doesn't get enough support? Well, when we start talking about essential workers and they don't have unemployment insurance or ready access to diagnostic or clinical services, you start to be able to unpack why the color of COVID is, again, it's often black and brown. I mean, the mortality rates have been higher, even in settings where the incidence or the risk of falling ill was in some ways similar. Then you still saw these divergences in delays in time to diagnosis, in survival, in morbidity after recovery. So we have some soul searching to do, and as an American, that has been and is still painful. That was the idea behind the Cary Lecture title. I don't know if I said too much, but
How can you say too much? Never. That's certainly not the case. But it's true. You are fond of alliteration, if you don't mind my observing. I am a literary person. I can't help noticing that. And I hope at some point to come back to some of your uses of language later. Don't worry, nothing scary. I can't believe I could possibly scare you, Paul. Anyway.
You're a comp lit professor. Of course I'm scared.
Terrifying to I know people just flee when they see you on the street. So, but now I've lost my train of thought because we were bantering. Um, but
I'm loving the bantering part.
well, there are the four S's, and I was always trying to remember what's the other one, like in a fish called Wanda, and the other one is system, and I think system is what we're absolutely weakest, I'm guessing, in this country, and I'm sure the audience will have questions on that subject for you later on. But I wanted to turn to something completely different, to stay in the Monty Python vein. even serious. And that is that we have, as I said to you before we started, we have many young people in our audience who are thinking about a career in public health or maybe already embarked on one. And so I wanted to ask some questions that are perhaps somewhat more personal or intimate to give them some ideas about how to do that. In Mountains Beyond Mountains, which I was bowled over by, but also gave me a lot of interesting thoughts about you and about the whole process. Tracy Kidder describes your formative years. And I'd like to know, what was the importance of friendship to you at that point, and how would you have functioned without it? Perhaps both of those, and elaborate
Wow.
as much as you like, because we have plenty.
Wow, that's a great question. I really appreciate it. You know, I know you asked me about my childhood, but I'm going to say that today, ever since I got here last week, I've been with friends. Some of them I worked with in Haiti for many long years. Others, getting back to young people, one was 15 years ago, was a young Sierra Leonean who just graduated from med school, the only med school, and had been a refugee. And I didn't know all these things about him, and I didn't meet him for years, but he said, would you help advise us? I went, sure, about global health. So, and he's now, and the director of Partners in Health Sierra Leone is a protege of mine, an American who worked in Haiti for 10 years. And he's passing on the baton to the young doctor I mentored all those years ago, who's not a young doctor anymore, but as an MD, a PhD from UCSF. I mean, these are people who have spent their whole adult lives, really, and I could go on, thinking about other people, and that's why we're friends, and we're intimate friends. I mean, we look out for each other. Even when we're on different continents, and so back to your question, what was, and I'll just tell you what I thought about. I had a lot of friends as a kid. I was very sociable, but I also came from a big family, and I'm friendly with my mother. My father died kind of young, but I'm very friendly with my brothers and sisters, and I really learned the art of friendship, I think, from my family. I didn't know, I knew that we lived in unusual circumstances, which now you know too, because you read Tracy Kidder's book. And just for the audience, that was 20 years ago, I think he wrote that. I lived a lot of my childhood in either a bus or a boat, and not a house. And then I went away to college and I lived in a dorm, et cetera, et cetera. So we were 8 people on top of each other. And you learn how to get along with others when and I see this all the time now in large families, in Haiti or anywhere else I might work, Rwanda. Large families in the United States are like that too. And that was a great blessing, I think, growing up in a large family. We didn't know that, we didn't know about some of the things that may have been on our side. Like, we wouldn't have known how to say white privilege, but we should have known that. We should have understood that growing up in rural Florida or urban Alabama. We should have gotten that. But our parents were good teachers too. And they taught us that we really had to get along. But I don't recall it ever being much of a chore. So that's probably way more information also than you wanted. But I did think of my siblings first. And
but I was thinking more specific. Sorry, this is all wonderful, and I don't mean to interrupt you, but you cannot talk too much, Paul, really. I mean, I'm often told that, but I'm sure you're rarely told that. And what I was thinking about—
You didn't grow up in a family of 8. I can see that, because I have been told that my whole life. You talk too much.
Oh, I was told that my whole life with fewer people now. Isn't that daunting to think about? But in any case, I was thinking about later on when you got to Haiti and met Ophelia Dahl. And
Oh, yeah. When you said childhood, I was thinking back in the day.
I sort of meant your formative years. Well, that includes childhood, of course. You're right.
And you're right. Well, no, I mean, I think certainly I didn't, when I was 23, I thought I was a big grown up. Now I know that wasn't the case. But yes, I'm so glad you brought that up, because the folks who founded Partners in Health, most of us were very young. I met Ophelia Dahl, who led the organization for 15 years when she was 18 in Haiti. And we had one exception, and that would prove very important, as you read. We had a friend who was not a student at Wellesley or Harvard Medical School or wherever, but who owned a construction company in Boston. And he was, when I met him, I'm 61, and I'm guessing he was about my age at that time. His name was Tom White. And the wonderful thing about your question, which allows me to reflect a little bit more on friendship, um, was that these youngish people, and they included Jim Kim, who was a classmate or went to Harvard Medical School when I did. We were in the same MD PhD program. Or Todd McCormick, my freshman roommate from college. You know, those that makes sense. But Tom White was our friend. We didn't regard him as the funder or some aloof person. He was someone who struggled through the joys and sorrows and losses of this work. Because if you're in close proximity to any clinical desert, you know, and I'm using that term as Americans use the term food desert. If you're in any proximity to it, it is a very loss-filled arena. And I saw it today, you know, and I walked in the emergency room. I had been there yesterday, you know, and, you know, one person who was there yesterday who looked, you know, like it wasn't a patient I'd been asked to see, wasn't there today, you know, and I know what must have happened. And the whole place was full of very, very sick people, and most of them young, some of them children, most of them, I mean, the oldest one looked like he was under 40. So, you know, when I say losses, our friend Tom was right there with us. You know, this was a group of friends. And we just decided, you know, there must be something we could do that would be useful. We were very focused on Haiti at the time, and still are. And that group of people stuck together. And in fact, Tom died at a respectable age, in his 90s. So that meant we spent a quarter of a century working together. And Jim and Ophelia and Todd, fortunately, they're alive and well. One of them might well be listening, for all I know. So we're still together. The difference is we're not a dozen people, we're almost 20,000 people. And that's how you water a clinical desert, right? You need a lot of people. You need staff in addition to stuff and space.
Well,
There, I tied that together with a bow.
yes, you did very neatly, and how fantastic. But if you were talking to young people today who may not have encountered this kind of serendipity, do you have any advice for people who are thinking of making a career in this field?
Well, now I could show off and prove to you, literary lion, that I know about the origins of the word serendipity, the three princes of serendip. They don't know in the novel that they're having serendipity all around them, right? They figure that out later. The reader knows, you know, and the comic novelist knows, but that's the advice I would give to young people and to my own students, whether at Harvard or in Haiti or Rwanda or here in Sierra Leone, is you don't know it's serendipity as it's happening. You got to stick with it, you know, find the friendship part. Nobody does anything in this kind of work without an army of people. I mean, some people won't like the metaphor, but a large group of people with, you know, shared intent and belief in a mission. It just doesn't work, you know. It's like I could launch women's health centers all day long, and it would lead to absolutely nothing, even though we laid down the bricks or the blocks with the Minister of Health. It was very hot yesterday too, I might add. But you need hundreds of people to build the thing and to staff it and to design it correctly. And we do have hundreds of people. So even here in a place where we've only worked for a few years, we have, you know, many, many hundreds of people. So the friendship part, that you can look for, and you should. I'm speaking to young people, and just find a group or a mission to believe in and stick with it. It might not be the same group. We're lucky, we stuck together. It might not be the same group, but if there's something you really care about and are passionate about, you got to stick with these things. It's not, I've been at this now for decades, and when people ask me a question here in Sierra Leone about how to design, a hospital, how to think about follow-up care for a chronic illness, I know what to say because just been doing it a long time, and I could be wrong and someone else will correct me. So the friendship and persistence part, those are really key.
Well, thank you very much, Paul. Maggie, is there time for me to ask one more thing, or should we?
Sure.
You've been so nice about everything, and now I'm going to ask you a sort of language question. I actually wanted to ask you some of these questions came from friends, like that one about friendship, but I want to be sure to acknowledge them. But as a language question was just that one of the things I noticed, it's completely different from your mission otherwise, but I can't help being curious, and that is that your group of friends, Ophelia and the rest of them, you all developed a kind of secret language, which I think you had within your family to some extent, I'm guessing. And also I realized that Ophelia also grew up with a secret language. And it made me think about all of that. For instance, I know that at least in your youth, I don't know if you still do this now, you had the expression WL for white liberals, which could be a lot of us. I know that describes me.
It describes me too. So.
And one of the things I was thinking about, which may be a little impertinent of me, is that when I watch the videos and films of you, as most doctors do, even though you're such a compassionate doctor, you turn to someone who speaks English and you explain what's going on with the case, which is another kind of secret language for the patient, really, because though you speak so many languages, they don't know what you're saying.
That's right.
And so this is a rather far-fetched thing, and then we could segue into the questions from the audience. But have you ever reflected on that, on the importance of having language?
It came up this morning. The Sierra Leonean doctors and nurses also address each other in English, and have. I'm sure for centuries, right? But that is not the lingua franca of this land. And, even if there's a fiction that it is, it's like saying Haiti's a Francophone country. It's not, there is a Haitian language, it's called Haitian Creole, and there's a Sierra Leonean language, and it's called Creole, same root. And to me, it's, now I'm starting to understand. And I think with a little application, that wouldn't be difficult to do, although that's not why they invited me here, to learn their language. I had my chance to do that a number of times, and I'm very grateful for it. I know why I'm here. But every day that I am lucky enough to see patients here, once in a while I have a patient who speaks English in the manner that I do, but mostly I need and remind anybody else who's within earshot that we all need to be careful and slow down. Even when someone, like in this particular instance today, the patients that I saw were all so sick that none of them had normal cognition. Like, one was delirious, another may have had a stroke, or certainly had something going on in the brain. Although one kid who'd been really very quiet yesterday was quite perked up today and almost chatty. But we do reflect on it. We reflect on it even in a place where everybody speaks the same language. But here they speak a lot of languages. And it's not like the United States where there's a couple languages. If you know them, you can get by. So we do spend more time. And a lot of times the students, or when I say students, it's usually medical students or residents, people who are already physicians or nurses. They do talk to me about anthropology and medical anthropology, and how does that play a role. And I try to think about that as well. But when we think about any kind of secret language or culture that's different, or a cosmology that's different. So what I tell my students, and I know this is again going over what you wanted, but I want to share it with the people listening today, that we should not be seeking cultural competence, which is illusory, You know, even when you do speak I mean, I speak Haitian Creole fluently, and, you know, I can write and read and all that other stuff in it. But that doesn't mean you really know a place to the point of cultural competence. So we try to push cultural humility. And we try to tell our clinicians, again, mostly nurses and doctors, but also community health workers, anybody else, so social workers, psychologists, is that the real prize for us as caregivers is cultural humility. And the rest can follow, that our secret languages and codes can be broken, and we can crack open the worlds of others with more easily with cultural humility.
Thank you so much. Maggie, we turn to you.
Sure, we have some questions coming in. I'm going to start with one from somebody who has been working on the front lines of pandemics, including the latest one. And this is Diana, who says, what advice can you offer for those in healthcare who are struggling with pandemic fatigue and burnout? You personally don't seem like you have any of that, and it's 12:30 in the morning in Sierra Leone, but can you speak to the question that she raises about clinician and caregiver fatigue?
Well, you know, first of all, don't be fooled by my chipper appearance, because one of the reasons that I don't appear, you know, burned out or sad about what has gone on is because I am here, right? Because let me put it in very clinical terms. My practice, my medical practice is so varied compared to almost anyone I know. There's a couple people I know who have an equally varied practice, but they mostly work with partners in health. So I can tell you that I would, after this last spring, you know, a year ago, I mean, I was so fried and frazzled by, you know, what was going on inside clinical facilities, but also outside, you know, how hard it was. And, you know, the real break for me last year, 2020, the real break for me was a chance to go to Rwanda and spend a month. And again, I don't believe that they needed me to be there. I don't think I made significant contributions in that whole month, but it was good for me, you know, to see a well-organized COVID response that had come on the heels of a very well-organized Ebola response. There were no cases of Ebola in Rwanda, but just over the border on their western flank in the Congo there were. So I do want to say, again, going back to Rita's question about friendship, you know, we do try and look out for each other, but you know, and was it Diana? I'm sorry, who asked the question?
Yes, it was Diana.
I just want to say I'm very fortunate in that regard. I do have a lot of you know, variety that you know, but some of my friends, you know, at the Brigham, you know,
Yeah.
they just don't have, you know, some of them are still just churning on through yet another surge, you know, and I know that I know people in India and Delhi, you know, who are friends of mine who are in the middle, or Mexico or Peru, you know, where I really have a lot of friends after many years of working there and caring about that place. They've just been working so much harder, you know, and they haven't gotten that break yet, you know, and a lot of us hope that with the vaccines, you know, there would be a break. But of course, Partners in Health can't look at vaccines as a fait accompli until they're in people's arms. So I do want to say, again, there's a reason to focus on cultural humility, but on humility in general, this can be hard work. And one of the ways to stay vital in the midst of it is, you know, to rely on your friends and family, but also you're lucky if you get some real variety. And I do get that.
Great, thanks for that. You know, there's a couple different questions that are asking about the incidence of COVID, not only where you are, but also in Haiti. And there's somebody who runs an NGO that does work in Haiti. And the question really has to do with how much COVID is there in Haiti, but also in Sierra Leone. And what can you tell us about the systems for tracking disease and whether perhaps there's a lot of prevalence, but it hasn't been tracked?
Yeah. Well, let me just start with Sierra Leone, and it's not an entirely different kind of situation in terms of what you're hearing. That is, low overall numbers of cases and exceptionally low mortality, right? So we're talking about, this is a country of perhaps between 7 and 8 million people. We're talking about a few thousand cases that are documented and fewer than 1,000 deaths. So obviously, if you did the math and shrunk down the United States to 8 million people, we'd still have done quite poorly compared to Sierra Leone and certainly compared to Rwanda. Now, one of the first things you're going to hear is, well, that's because of the age structure of the population, right? They're young. And it is a very young continent, and it's a very young country in terms of the age distribution, right? But that's a cop-out, There's obviously a lot going on because even with age match comparisons, Rwanda still looks great and Sierra Leone doesn't look bad, right? So there are clearly other factors. Is it just poor reporting? Well, don't forget, Sierra Leone just went through hell with an Ebola epidemic that began in 2013 and was recognized in 2014 and went on for 2 years, And by the way, contact tracing helped to end that epidemic, that and a vaccine. So there's some lessons to be drawn for COVID, even for Massachusetts, if you ask me. But this place is not the clinical desert it was after the war or at the beginning of the Ebola epidemic. There's a lot more people who know about things like reporting, contact tracing, community health workers, social distancing. I'm not looking around and seeing, a lot of social distancing, but you can go to parts of the United States and don't see much of it there either. So I've already now gotten to 3 factors without even mentioning that it is also within the realm of possibility that they're doing a good job. And in Haiti too. I mean, my colleagues and Partners in Help Haiti is called Zami La Santé, and is our biggest operation, 7,000 people, running the public hospitals from the Dominican border all the way to the coast on the other side of the country, across the country, serving millions of people. And I happen to know that they run a tight ship, and I know that they're in charge of the clinical response, and the referral center is in Central Haiti because of them. So I bristle a little when I hear someone say, well, in Haiti, it's all because they don't have a good reporting system and nobody knows what's going on there. I have 7,000 colleagues, and believe me, they know what's going on in their communities. And, here in Sierra Leone, in the district where I was this morning, which is over where the diamonds come from in the east, I have hundreds of colleagues, and a lot of them are community health workers. A lot of them are nurses and doctors. A lot of them are managers. A lot of them are drivers. A lot of them are, health promoters, whatever we might want to call those. So I don't buy that, poor performance, weak surveillance systems, and general incompetence explain much of anything. It is true that do we know enough about the variants that are here? Of course not. We don't have the lab capacity, but we have more than we did back when Ebola started. So I just want to have Americans listening, the Cary Lecture think, well, sometimes they're actually really working hard and doing a good job. And that's my impression of my colleagues who I've been with this past week here in Sierra Leone. And I know for sure that Rwanda is doing a bang-up job. And we have a lot to learn from Rwanda, I think, as a nation, meaning the United States.
Well, actually, let's stay with that for just a minute, right? Because you make a good point that some of these systems that Partners in Health set up, Partners in Health also was very involved in contact tracing early in Massachusetts. But I'm wondering, did that effort, and nationally, those efforts on contact tracing, was it a wildfire that got out of control too fast? That wasn't enough that contact tracing wasn't enough to help control it? Or what do you think about the role of contact tracing maybe not having helped enough in a country where we weren't using it properly?
I don't think we were using it enough, properly or not. You can't, with the possible exception of, Massachusetts, to point to an entire state where there is adequate contact tracing. Even in Massachusetts, it wasn't adequate. And what I mean by adequate is every time there's an outbreak, every time there's a positive lab result, you're spending time trying to find out who's been exposed so that you can offer that contact, they're called. It's an unattractive term, but supportive isolation, right? So now there are a lot of myths about contact tracing. First of all, I'm just going to say, flat out, for us at Partners in Health, we learned contact tracing really as a collective in Rwanda, Sierra Leone, Liberia, Haiti. But we already did contact tracing. My first job as a medical student was as a Creole-speaking contact tracer for the city of Cambridge. Right? So this is a well-known intervention in public health, right? And it was well-known in 1918 with influenza. It's well-known. It's probably less well-known now when we have overweening confidence in the other tools. Like, they were waiting for a vaccine for influenza. It took decades to develop one. They weren't even sure what it was. So we're lucky that we have new tools quicker now. But we always needed more contact tracing. And let me just say that in writing about Ebola recently, or AIDS, or drug-resistant TB, or cancer care in Rwanda, or whatever, the thing that drives us crazy is what we've been calling clinical nihilism. And that is when you say, well, this disease is really not treatable in such a setting of poverty. You could even make it sound WL, Rita, where it sounds like prudence, right? Prudence leads the virtues. Well, this is really not cost effective in such a setting, not sustainable. And then you realize that you're really getting to, it's not even prudent to try to treat these people. And who are these people? Well, they're mostly Black and brown people. So what we're often doing with clinical nihilism is expressing our pessimism on behalf of other people, right? In the United States, it's very hard to sell that. Like, you can't go to Brooklyn and say, oh no, that's the Manhattan standard of care. For Brooklyn and this part of Brooklyn, we have a whole different plan for you. Imagine, that's been tried in the United States, and we have ample documentation of it, and it's resisted vigorously, right? What we've had here, there in the United States, has been a containment nihilism. So after the president of the Republic fell ill with COVID, and the disease was known to have been propagated in the White House and in the Rose Garden, look at what the president's chief of staff said. He said, we're not going to stop this epidemic through containment. We're going to stop it with a vaccine and medications. And it's kind of true what he said. We didn't stop it with containment. We should have, because what we should see in our mind's eye are two slopes down. You get a good vaccine, or several of them, you're going to see improvement, right? And so we should be expecting fewer cases and obviously fewer deaths. But if you want to see it go down really quickly, you should do what Rwanda's trying to do. Vaccinate everybody, start with those most at risk, respond to epidemics, outbreaks, clusters with the vaccine too. We're not doing that yet in the United States. Have local vaccine production so you don't have to rely on outsiders all the time, people from another continent to, even sell you the stuff, right? So we can see a sharper decline if we continue to think about contact tracing, social distancing, mask wearing, all kinds of precautions that could just make that decrease more quick. And the reason to do that, of course, is the difference between those two slopes is new cases and deaths.
Yeah.
And I've, like a lot of people listening, I've lost family, friends, and patients, and even colleagues to this disease. And so there's lots of reasons for me and many others in medicine, meaning nursing as well, to wish for a more rapid decline. That's not going to happen with, uneven vaccination alone.
Yeah, it's critical that you're saying you can get there, but through so many deaths and loss of life, it doesn't make sense. There's a couple questions that are related about, there are questions about whether you face some of the problems that we're facing in the US now. And those problems, political divisiveness is certainly one of them. And the other one is a growing sense of maybe vaccine hesitation or anti-science feeling. Do you find those in other places? And do you have any lessons learned from other places in the world that we could apply here in the US for those problems?
That is an awesome question. And I will just say, I've never not seen it. But let's pick that apart, vaccine hesitancy, political division. First of all, political divisions, I'll just say it. I think my host here would just chuckle. When you're launching a new hospital for women, and if you're a doctor, like my colleagues, or nurses, matrons, as they say here, you're not used to thinking of women's health in political terms, right? You're not used to thinking about mask wearing in political terms or vaccination, right? And there were a couple of jokes yesterday where I realized these people who've come together, parliamentarians, mayors, the bureaucrats who are both politically appointed or the technical ones, a lot of the politically appointed ones, like the Minister of Health, also these are senior technical people, right? But then you realize suddenly oh my God, they must be from all these opposing political parties,
Yeah.
But I only thought of it when someone made a joke, because that's not why we were there. So the political divisions, I haven't seen a lot of that in Rwanda. I've been working there for 15 years and I just haven't seen a lot of it. I've seen plenty of it in Haiti, plenty of it in Mexico, plenty of it in Peru. Peru, just this year, in the middle of all this misery, they had 3 heads of state in just a few months, So political division, yes, we see it everywhere. But does it have to mess up our interventions in public health and medicine? No. We have to fight back and say this cannot be politicized. Like mask wearing, that's just ridiculous. It's either effective or it's not. It's either sensible or it's not. But to be Republican or Democrat is just absurd, right? So that skepticism that I'm describing to you is, yeah, I know there are political divisions all over the world, but they don't need to, people can come together and agree, women shouldn't die in childbirth. Women should have, access to prenatal care and family planning. We can agree on that across all kinds of political venues. So I'm skeptical when it's used as an excuse for inaction and any kind of nihilism, clinical or containment. To the second question, okay, vaccine hesitancy is a real thing. It's certainly a big deal in the United States, right? But again, if you go back and look at the history of colonial medicine, here in West Africa, which I had never done until, I started working here. And let me tell you, it's not a pretty story. But you would hear the same thing from the colonial medical officials, like, well, the natives, they don't believe in modern medicine. They're also superstitious. They don't want a smallpox vaccine, right? Whereas the missionaries, the business people, the teachers, they're describing lines of people out the door to get a smallpox vaccination. So those can't both be true, right? And what I would caution everyone is, yeah, we should worry about vaccine hesitancy, but there are ample reasons for mistrust in many, just going back to the country I was born and raised in, who can go into, Navajo Nation with a straight face and say that they don't have reasons for wanting to understand more about the vaccine and how they themselves would administer it. By the way, they have very high rates of vaccination on Navajo Nation. They're among the leaders in the United States. African Americans who don't know about the history of the Tuskegee, I haven't met many of them, and I'm not talking just about my med students and colleagues, I'm talking about patients. in the United States. So understanding that the term vaccine hesitancy can mask a whole lot of subtleties that are important to understand, that's just a, an analytic shortcut we should avoid. And we should also note that why should an elderly, frail person have to go to a hospital or even a clinic to get a vaccine? I mean, we take them to people's homes and whenever we can. That's how we do vaccination campaigns, at least to their village, or their neighborhood in a city. So it's also terribly inconvenient. If any of you, my mother is hardly frail, and I don't even think of her as elderly. I mean, the woman ran a 10K race recently. I had to call a friend of mine in Orlando, a surgeon who has nothing to do with vaccines, to help he and his wife, to help my mother get her vaccine. This is not easy. I didn't want to fill out the form online, and I got mine at my home hospital, the Brigham. So all this to say, I know that vaccine hesitancy is a big issue, but there's a lot going on under that rubric. And the way to build trust is to serve people. You don't think there was I feel like I'm being rhetorical because I know that you don't think what I'm about to say, but you don't think that there was a lot of mistrust during the Ebola epidemic? There was an average of 10 attacks per month on burial teams, right? In Guinea, in any case, and probably wasn't that different in the, over the border where I was. But we didn't have any attacks on us as caregivers because everybody's like, there they are right there, that you can see what they're doing, We heard that they're, spiriting people away, but we can see they're not. Mm-hmm. So I'm a real believer that, you got to build trust, and it can be done, fairly rapidly too. So again, this is a long disquisition on vaccine hesitancy and political division, but I think it's important that we're a little bit skeptical of those two things as the determinants of whether or not we do a good job.
Yeah, that's a great point. I don't know how much time we still have with you. Hopefully we can go through some more questions because there are
my dance card only has Rita Goldberg on it. I don't have a lot going on at 101.
I'm not talking for a change. This is so fantastic.
So Manuel and Susan are asking a question about kind of the interaction of the impact of COVID-19 and other health problems. So polio, tuberculosis, AIDS, Ebola. I mean, these are all devastating diseases. How do you see their interrelation?
Well, it's again a mixed bag that's worth parsing. Can you parse a bag, Rita? I don't think so. See, I'm self-conscious.
Or so can you. That's my answer.
Well, you look at influenza. COVID had a big impact on influenza. We didn't have any, and there wasn't an influenza season yet. So is that because of mask wearing and social distancing? Probably, right? But, are there other ways that one respiratory virus can be crowded out by another? Probably, right? Surely. And so when you think about some of the other health problems, it might be good to remember that there's some that may have been lessened, by, if there's a shutdown and less traffic, you have fewer traffic accidents, et cetera. However, most of the toll has been very negative and, very heavy. Anything that, I'm particularly concerned about people with, diabetes or malignancy who are in the middle of a chemotherapeutic regimen or who really badly need a hip replacement or a knee or, these are the kind of patients who, I take care of, not just at the Brigham, but, we have patients who meet that description in every place that we work. So, but then, I've also seen, so my major worry is not about influenza. I just am noting that once in a while there's a windfall. My major concern are those chronic and serious ailments and the decline in our ability to provide good care, particularly good outpatient care for those patients. So what's happening with the sudden, an acute myocardial infarction, what's happening with someone who really needs their chemo. Now, I did see something that's worth sharing with such a large group. In Rwanda last August, one of the first things I did, and they were super strict there about where I could go and where I couldn't go, only to do with COVID, right? So like I was among those who helped to found a university in Rwanda, and I went there to teach. I teach there. And did they let me go on campus? No, they did not. I had to teach via Zoom, as I had been doing at Harvard, even though I was in the country. But I did get to go to the hospital, and I talked to my friends in the cancer. I'm an infectious disease doctor. I don't know if you said that, but a lot of my patients have other problems. They have an infection and cancer. So I was really keen to check on, well, what happened to all these patients? This is a rural area. Some of them are coming from other countries to get their care in this Rwandan hospital, believe it or not. And what I found out is with the decline in travel, everyday travel from the team, like some people, they got to their hospital, they're mostly Rwandan, of course, the vast majority, and stayed put. That freed up the fleet of vehicles, and the drivers, some of whom are good friends of mine over the years, the drivers were hell-bent on either getting chemo to patients, including some in Burundi, Uganda, DRC, all around Rwanda, but also to bring them back, the patients, if they weren't doing well, And so again, the can-do spirit of getting around these terrible barriers and delays would serve us well. And we've learned that some of the things we were doing in person probably could be done more safely and more conveniently for patients via other methods.
Yeah, that makes sense. And that's that sort of transformation that can happen during a pandemic, sometimes even maybe easier than in regular times. So just to get maybe a little bit more back to the personal questions again, somebody's asking about whether there's either faith or a set of personal values that really drives you, because you're so committed and you're devoted your life to these really big problems and questions. And so they're wondering if there is something that's motivating you that you can share with us.
Wouldn't it be hilarious if I said, that's none of your business? I'm not going to do that. I want to preface what I'm going to say by saying I don't regard religious faith as necessary to have these values. I work with plenty of people who are completely and resolutely secular, as are, most of my mentors, or many of them, right? But I personally get a great deal out of my own faith. And, if I had, I grew up nominally Catholic. My parents didn't really care that much about it. We'd say, then why did you make us go through First Communion and all that stuff? And they would say, your grandmothers wanted you to, which, is good enough reason. But then, working in Haiti, going to Haiti as a 23-year-old and learning, I sort of relearned, a lot about the value for me in any case, during those years. And I remember even moments where, I would hear something in Haiti, like, for example, the expression, the corporal works of mercy. And I thought, oh my God, I remember that from Sunday school. I didn't know what it meant. But now it, like, feed the hungry, clothe the naked, visit the prisoners. I was already doing that, and that there was a code for that, a moral code, a code of injunction in a way. I'd forgotten all about it. And then, I thought maybe I should read more about liberation theology, because I was bumping into people in Haiti and then in Peru and then in Mexico, particularly in Latin America. I said Peru, I imagine, because one person in particular, Father Gustavo Gutierrez, became a mentor of mine. I was already a huge fanboy. I bet he doesn't even know what that means, of his. But and we ended up writing a book together. I should tell that Haitian lady, yeah, I wrote a book with a Peruvian. But you know, and it grew. I mean, again, I don't want to sound mystical. Not out of embarrassment. I don't mind sounding mystical. I just don't think I am very mystical. But I find this very, very helpful. And others have other ways of deriving the same kind of spirit of service, particularly service to the, as we would say in theological terms, to the shafted. That's, you know, here I am. I'm in a majority Muslim country right now, you know, and everything here is always super ecumenical. You know, you can bet every time if you launch a women's hospital, I can tell you from experience yesterday, you will hear prayers, you know, Muslim prayers and Christian prayers laid out just like that. The director of Partners in Health Sierra Leone was complaining that there weren't Jewish prayers, and he felt left out, although he was just kidding. So, you know, I'm just saying, again, that is a very personal question, and I've given you an honest answer. But like my own, you know, siblings, who, you know, we grew up in the same bus. This is not how they roll. You know, they don't. That's not what they took away from our childhood Catholicism, and I didn't either. Really, it was something I kind of got a booster dose, if you will, with effective against a new variant, and I owe a lot to Haiti for that, and also to Peru.
Yeah, thanks for answering what is a very personal question. I think people listening are just inspired by your story and trying to understand better how, you know, your personality and your source of energy for what you do. So Rita, I just want to stop and see if you have other questions.
One last thing.
Yeah.
Like just today, you know, I saw a photograph of a patient that I met. This was I thought she was maybe 12. This is just a few years ago. And I'll have to check, but and she had drug-resistant tuberculosis, and you know, just a wraith, really dying of the disease, but also of inanition, malnutrition, whatever. And you know, nobody here had ever taken care of a child with the drugs that we were recommending, and also Partners in Health was supplying to the National Tuberculosis Program and with the National Tuberculosis Program. And I don't forget patients very easily, you know, and I'm not bragging about that because I can't remember jokes, and you know, but if it's a patient or a lab or an X-ray, I could like have this little image, and I still have that for her. What I didn't have in my mind was what she might look like, you know, at 16, cured of her drug-resistant TB. And I didn't even recognize her at all. And so I wrote back and said, this was from the director of PIH Sierra Leone. He sent me the picture. And I said, who is this? And he told me, I went, you're kidding. And I'm just saying, if you don't have faith in God, if you don't understand the corporal works of mercy, that's okay, right? If you're not sure where to find, you know, some kind of religious faith, but you can find faith in humanity when you regularly see things like this. And what could be more affirming, even after a tough day, tough morning in the emergency room, seeing people are really, really sick, than seeing that. And I get to see that all the time, and so do my coworkers. And I hope that people who support Partners in Health or this kind of global health equity work can also take some of that very deep satisfaction, almost spiritual satisfaction, from that kind of work. And then I prolong that so I could add that on.
No, well said. Well said. I appreciate that. Rita, I'm going to turn it back over to you to see if you have any other questions, and if we're going to be wrapping up in a moment.
Well, I'm a little concerned about the time, even though I know Paul will go on for a long time. He looks very relaxed, but it is getting on for 12:15, and I mean, I know that people say about you that you don't sleep, but I'm sure.
Oh, I do. It's 1:15, I might add.
Oh, sorry, 1:15. I can't add. You know, that's a different branch of knowledge. No.
Yeah, I'm not good at that one either.
Well, one of the things I just want to ask one more quick question, which you can answer briefly if you like, because we really probably should wind up. You know, maybe this is a kind of mercy to you, you know, being protective. But I was struck by that because another person sent me your op-ed, which I must have read in the Globe last spring, probably March of 2020, in which you talked about the quality of expert mercy. And I was struck by that term because you're an expert and you're merciful, and we've just talked about mercy and its religious connotations, rather than say the more secular term compassion. And what can people do who are not going to be doctors or public health people, but would like to at least be compassionate, even if they're not experts? Maybe we can wind up with that.
Well, you know, I just want to say, Rita, that my experience, and I'm not a sheltered person by any stretch of the imagination. It's not like you can't say, oh, Paul Farmer, he's a Harvard professor, he lives in an ivory tower. Even if it were just the Brigham, you know, that's not medical professors are not living in an ivory tower. I still believe that most people are compassionate. In my experience, it's like, I can tell you, I rarely have cause to question that. I certainly didn't today or yesterday or last week. So it's something I see a lot, and I would say, think about the corporal works of mercy. I mean, after all, one of them is bury the dead. Another is visit the prisoner, give food to the hungry, shelter to the homeless, clothe the naked. These are, to me, I mean, these, you want, if you don't want to use religious language or even the word mercy, look at the Sustainable Development Goals or something. You know, there are many different ways to think about compassion, mercy, and solidarity. But the best way, I would say to anybody listening, is think about pragmatic solidarity. Expert mercy, the idea behind that comment or term, which I'm sure I didn't make up, although now everybody thinks I made that up too. The idea behind it is, you know, you want someone to be merciful, but they need something when they can't breathe. They need something when they're bleeding out and having a baby. They need something when they're, you know, coughing up bright red blood like someone I saw yesterday. So expert mercy is not just for doctors. You know, who's going to visit the prisoners? Who's going to think about, you know, people who don't have food security or water? 80% of the people in Massachusetts who, first of all, 80% of the people who we're trying to contact answer their phone. So people say, well, no one's going to answer the phone. That's wrong. We even hit 90% when we had adequate staffing, right, in Massachusetts. But among those who had a problem that they would describe to us that would prevent them from, you know, protecting themselves and their family members, 80% of those people said their biggest problem was food insecurity. So there in Massachusetts, where you have beautiful pearls of a town like Lexington, 80% of the people who are struggling with COVID are struggling with food insecurity. And that's not an estimate. That is the result of a survey that my colleagues are doing with their public health peers in Massachusetts. So I think that there's so much we can do to show we are compassionate, but just talking about it is not really good enough in the middle of a crisis like this.
Well, thank you for that. I hope all of us non-expert people will think about that as well. So shall we wind up? Yes, Paul, would you like to say something about this last screen, because it's all about you?
Let me see. Well, Porter Square Books is my favorite bookstore in the region. I wrote that book, as you can see. The movie, anyway, the book is about Ebola, but there's a lot about COVID. I could say that. Is that legitimate, fellow author?
Is that you're asking me?
Yeah. I don't want to feel like I'm plugging my own book, but.
Of course you can.
Anyway, I'm glad I wrote it. It just came out.
I've read about 60 or 80 pages of it so far. It's quite a long, large book too, right? So it has a lot about the history of the
Got a
diet.
lot about the history of West Africa. By the way, one thing I can tell you with confidence is the Cary sisters would have loved it
Because
I said so.
I'm sure they would have. They did a lot, that's a great way to end. Anyway, Paul, it's been such a pleasure. It was a pleasure to meet Katie, your assistant, as well.
She's sitting right here. God bless her.
Well,
119 for her too. And I would just say, even though it's not very seemly, that I'm sending you, Rita, a big COVID-free hug. And thank you for a wonderful evening.
it was
And
marvelous.
thank you, Maggie.
All of us, thank you so much. We're so grateful you came. And that's how we started. You gave me a hug at the other end.
And it won't be the last time. And Mina and Kevin and John, I know we can't see you, but I'm thanking you for a warm welcome back to Lexington while in Sierra Leone.
And see you back in the same.
Thank you very much, Paul.
Bye-bye, Paul.
Bye, everyone.
Take care.
Thank you.